The title of this presentation is Twiddler Syndrome, a hidden culprit behind abdominal pain and pacemaker dysfunction. This is a case report of a patient of Dr. VJ, an EP physician. I am joined by my colleague Marc. We are both fourth year medical students applying into internal medicine. So, Twiddler Syndrome is a pacemaker complication after implantation, which are a rare occurrence. So, Twiddler syndrome refers to a patient's manipulation of a pacemaker or AICD device resulting in permanent malfunction. The sequelae of symptoms typically begins with the patient's intentional or subconscious spinning of pacemaker pulse generator within the capacious pocket. As a result, the leads are dislodged and ventricular pacing ceases. With continued reeling of the leads around the generator, the ipsilateral nerve can be stimulated, causing diaphragmatic pacing and the sensation of abdominal pulsation, which can be described as bilateral cochlear pain slash discomfort. As the leads are further wrapped around the generator, rhythmic arm twitching can occur due to stimulation of the pacing of the brachial plexus. Improper lead placement leaves the patient at increased risk of bradyarrhythmias or asystole. So, risk factors and epidemiology of Twiddler syndrome: most cases are diagnosed within the first year of implant. A retrospective chart review study was performed on all patients who underwent cardiac device implantation from 2017 to 2022, and 21 out of 1,793 patients, or 1.2% of the population, were identified as having Twiddler syndrome after chart review. It was found that patients who were on antidepressant medications were at higher risk for device manipulation, which can be subconscious. So, independent predictors include female sex, antidepressant medication use, and increased BMI. Here is a chart of independent predictors of Twiddler syndrome, the odd ratio of Twiddler syndromes with female sex, antidepressant, and BMI. So, regarding the case itself, the patient was a 54-year-old female, presents to the ED with syncope and is admitted for syncopal episodes in normal sinus rhythm. Past medical history is significant for hypertension, osteoarthritis, obesity, with a BMI of 39. After admission, the patient continued to complain of palpitation, dizziness, lightheadedness, and shortness of breath. She denied any chest pain, orthopnea, paroxysmal nocturnal dyspnea, or lower extremity swelling. 4 days after admission, the patient developed paroxysmal AV block with associated syncope. Dual chamber pacemaker was planned. The patient tolerated the device placement well, with no complications noted during and after the procedure. Discharge plan is outpatient follow-up and device interrogation in 3 months. Here is a reference chest x-ray of the typical placement. This is an example of a dual chamber placement or pacemaker placement on chest x-ray. Arrow shows preferred tip positions, which are the right atrial appendage and the apex of the right ventricle. So, moving back to the case presentation again, the patient presents for outpatient follow-up 5 months after pacemaker placement. Patient was recently seen by her PCP for abdominal pain and was given muscle relaxant for muscle aches. Patient denied any chest pain, but has been having colicky pain both in the right and left sides. Upon device interrogation, lead thresholds cannot be read. When questioned, the patient admitted to repeatedly fidgeting and manipulating the permanent pacemaker generator in the skin pocket on her upper left chest. Due to clinical presentation history, Twiddler syndrome is highly suspected, and chest x-ray is done to confirm the suspicion, and lead revision is planned and performed. Here's the pre-op lead revision image, chest x-ray demonstrating evidence of Twiddler syndrome. The green arrow shows coiling of the proximal lead around the pulse generator, and the red arrow shows displaced tips within the capacious pocket. Here is the post-op lead revision. Remember, it was a 54-year-old female patient with 2 bi-chamber pacemaker after lead revision. The red arrow shows preferred tip position on the right atrial appendage, and the blue arrow shows preferred tip position on the right ventricle. Here is a side-by-side comparison of the correct and incorrect lead placement of the dual chamber pacemaker patient with Twiddler syndrome. So in the end, the patient tolerated the lead revision well and no surgical complication was noted. Patient underwent general anesthesia, after which the capacious pocket was reopened and device was removed along with the tangled proximal leads. Due to the damage of the atrial and ventricle leads, they were replaced and then reinserted via catheter into the right atrium and right ventricle appropriately. The original pacemaker was reconnected in a new lead and implanted back in the capacious pocket. A chest x-ray was done to confirm the appropriate lead position. Patient was discharged for outpatient follow-up in 2 months and counseled against further twiddling of the device. So moving on to the discussion, manifestation of the Twiddler syndrome varies depending on the degree of entanglement, subsequent retraction of the electrode, and the final site of the dislodged lead. Leads that dislodge in the abdomen may stimulate ipsilateral phrenic nerves, causing diaphragmatic contraction presenting as involuntary respiration, hiccup, or abdominal pain, as in this patient's case. The risk factors include female gender, obesity, and elderly age, impaired cognition, and a smaller size implanted device relative to its pockets. The associated laxicity of the subcutaneous tissue, especially in the elderly, facilitates further dislodgement of the device. Chest X-ray is the simplest tool of diagnosing Twiddler syndrome, and it provides a clear picture of the leads coiling and the device rotation. Treatment of the case includes uncoiling of the leads, implantation of the new leads, and repositioning of the pulse generator. Since the lax subcutaneous tissue permits device rotation, the goal of minimizing the pocket size or utilizing sutures to fix the generator in place may prevent occurrence of Twiddler syndrome. One article advocates for suturing the device to the fascia in patients with mental disorders, confusion, or lax subcutaneous tissue. Despite more stringent procedure efforts, proper patient education counseling of caregivers is the most effective method to avoid manipulation of the device and preventing further consequences. So in conclusion, Twiddler syndrome is the most common cause of early pacemaker/ICD device failure. Standard protocol for device follow-up should include cardiac exams and device interrogation. Our recommendation upon reviewing the case would be to include Twiddler syndrome and differential diagnosis in patients who complain of unspecified abdominal pain after device implantation.